Hello, this is Dr. Philip May. I'll be speaking with you today about the basic evaluation and management of recurrent seizures in adults with neurodevelopmental disorders. A seizure is defined as the sudden onset of uncontrolled brain activity that is associated with unwanted subjective experience and or observable change of motor behavior. So the point is that a seizure is really a brain problem. It starts in the brain, and it's the brain activity that defines what a seizure is, and then it has a clinical manifestation, which can be either subjective or something that other people can observe. Epilepsy is defined as simply recurrent seizures. A simple classification of seizures can be based on the onset pattern, how it starts in the brain. Now, seizures always have a specific site where they start, but the EEG electrodes, which are on the surface of the brain, cannot necessarily detect where that seizure is coming from. It could be starting in the brainstem, and the EEG electrodes will not detect that. So when it spreads to the surface of the brain, then the electrodes can read it, and in some instances there will be one part of the surface that will start. There will be a focus, and it will not start looking like a generalized seizure. It will start as a focal seizure, as a partial seizure. So seizures can be classified primarily into partial versus generalized onset, the way it looks on the EEG and the way it may look clinically. So, for example, if the person suddenly develops tonic-clonic activity, or has an absence seizure, just kind of stares off into space, this is a generalized problem, but there is a place in the brain where it starts. And when you do an EEG, you may see, certainly in like temporal lobe seizures, you can see the partial onset. It'll be starting in the temporal lobe and then spread to the rest of the brain. Now, partial seizures can be subdivided into simple and complex. So a simple partial seizure is a seizure that is associated with one localized motor activity, for example, a shaking arm, but the person is alert. There's no alteration of consciousness. If there is alteration of consciousness associated with the shaking of the, say, left arm, that would be a complex partial seizure. So if you had a brain tumor on the right side of the brain, this may lead to a shaking of the left arm. If the person is fully alert and there's no alteration of consciousness, you would call that a simple partial seizure. Whereas if there was some dulling of consciousness, then it would be a complex partial seizure. On the other hand, if the seizure is shaking all over the place, whether it's a tonic seizure, a clonic seizure, an absence seizure, or a tonic-clonic seizure, this would be a generalized seizure. Most of the seizures we see are actually tonic-clonic. It starts with a rigidity, which is the tonic phase, and then a shaking, which is the clonic phase of the seizure. Now, probably in developmental disabilities, there will be a partial onset with secondary generalization, although you may not clinically detect the partial onset. In other words, it could be a start with a shaking of the left arm, and then it spreads to the right arm, then the legs, and then the whole body is having clonic activity. But usually we miss that partial onset. What we see is the secondarily generalized seizure. Okay, now this is the way we diagnose seizures with the EEG. The gold standard is the video EEG, and this elderly person is sitting in a chair with the electrodes on his head, and the camera is rolling. And you can see at the bottom of the slide here, it says the beginning of clinical seizure, generalized tonic-clonic activity. Notice the leads. There are 4, 8, 16, 20, 22 leads, and then an EKG at the bottom. And all of those leads develop seizure activity, and they all start at once. And you can see all of them are demonstrating abnormality of seizure. And you can see the red line is basically where it starts clinically, although you can see a little seizure activity on the EEG just before the clinical onset, and that could be determined by the video that's created. So he may have experienced some subjective experience before you actually saw the shaking there. But this is a typical video EEG, and I'm going to on the next slide, I'm going to show you an example of a partial onset seizure where only some of the electrodes are demonstrating seizure activity. And this is a mesial temporal lobe seizure, and you see where the blue stars on the right are those leads. There are about 8 leads. They look different from the other leads, which there can be a little bit of a spread of activity to the other leads. They're not completely the same, but you can tell that this is only a part of the brain that's seizing, and it's the mesial temporal lobes is demonstrating seizure activity, and clinically that will be manifested as in this individual random movements, lip smacking, could stand up and push a table away. And the important thing is there's alteration of consciousness. There's a lack of response to verbal directives. So if this person were named Joe, you could call his name and there would be no response. So he's demonstrating some behaviors which may be kind of bizarre, but there's no tonic-clonic activity. And so this sometimes behavior problems can actually be seizures. This individual would have these spells, and this is a person with a severe developmental disability, and lived in a home with his family, and it was an older person actually who'd been having these spells for many years, and they felt he was just being uncooperative, but actually he was having seizure activity. Now, what causes recurrent seizures, or epilepsy if you want to call it? It's the dysfunction of the brain that may be caused by hundreds of different genetic or acquired disorders that may develop in childhood or adulthood. And for persons with developmental disabilities, it's important to make the neurodevelopmental diagnosis. Now, what do I mean by the neurodevelopmental diagnosis? Okay, people with developmental disabilities actually have neurodevelopmental disorders, and these are genetic or acquired disorders of the brain that first become clinically apparent in childhood, and they're associated with measurable biochemical or structural brain abnormalities, and may be associated with 4 major symptom categories: cognitive problems, motor problems, behavioral problems, or seizures. And these particular categories of symptoms It can occur either singly or in various combinations. You can have somebody with a severe cognitive dysfunction and seizures, but no behavior problems and no motor dysfunction. Or you could have somebody with a really bad behavior problem who also has seizures. So you don't have to have all four, but these are kind of four siblings that you see again and again. And when you evaluate somebody with a developmental disability, you need to think, what is the neurodevelopmental disorder which is associated with this developmental disability? What exactly is the disability? Is it cognitive? Is it motor? Is it behavioral? Or is it seizures? Or does this person have all four of these symptom complexes? So it's a little bit of a different thought process from saying the person has a developmental disability. For the physician, they need to dig a little bit, go under the surface, and try to determine what the actual cause of that disability is. Now, neurodevelopmental disorders can be classified into the genetic or acquired varieties, and genetic neurodevelopmental disorders can be subdivided into biochemical, chromosomal, or structural. Examples of biochemical disorders are phenylketonuria and homocystinuria, which you may encounter these cases. They're not very rare. PKU is much more common. And sometimes the people do not get appropriate newborn screening for PKU, and it still occurs. It's still a possibility. Certainly in the older adults today, they may have missed the screening, which began in the 1960s. Chromosomal problems such as Down syndrome, which is an aneuploidy, and Angelman syndrome, which is a deletion on the chromosome 15. There are really hundreds, if not thousands, of these different chromosomal problems. And structural problems associated with tumors, such as tuberous sclerosis and neurofibromatosis type 1, you may see. And all of these are important conditions to know about, because you will see them if you have a practice that includes a lot of people with developmental disabilities. On the other hand, there may be acquired conditions which can be subdivided into prenatal, perinatal, and postnatal. For example, fetal alcohol syndrome or congenital rubella syndrome, which can occur prenatally, perinatal hypoxic encephalopathy, and then postnatal lead poisoning, measles encephalitis, or brain tumor. Don't forget brain tumor. They can occur in people with developmental disabilities and may explain some of the motor dysfunction or behaviors. This is not, I would say it is uncommon, but you will see this from time to time. Now, the four major complications of neurodevelopmental disorders I went over before, just to review: cognitive, motor, behavior, and seizures. And we're talking about seizures here. And it's important to emphasize that seizure is not a neurodevelopmental disorder. It's a developmental disability, okay, but it's not a neurodevelopmental disorder. A seizure is a symptom of a neurodevelopmental disorder, just like a cough is a symptom of pneumonia. So you can treat the cough symptomatically, you can treat the seizure symptomatically, but you really haven't diagnosed what the cause of the cough is or what the cause of the seizure is until you try to determine the precise neurodevelopmental disorder which is responsible for that seizure, and there's always a cause. Now, you may not ever figure out what it is, but I would say if you really try to, 95% of the time, you will be able to establish the neurodevelopmental disorder that is responsible for that seizure. Now, in the initial evaluation of seizures, the first step is a careful a description of the observable motor behavior and or the patient's subjective experience, because it's important you're going to have to count the frequency of these seizures. You need to know what it is you're counting, and so that everybody's on the same page, whether it's a family or staff in a developmental center or in the group home. Everybody needs to be counting the same thing. And sometimes the physician will evaluate the quote seizure unquote and determine that there's really not a seizure that's going on. It's a seizure-like activity perhaps, but it may not be a seizure. If a video of the motor event can be obtained, that can be very helpful. In step 2, there's a documentation of the uncontrolled brain activity that underlies the motor behavior and or subjective experience, and that's done with an EEG, a SPECT scan, PET scan, or a functional MRI. In step 3, the diagnosis of the underlying neurodevelopmental disorder that is responsible for the seizures can be obtained by performing an MRI, genetics testing, biochemical studies. There can be other approaches, whether you're dealing with a medical geneticist or a neurological or a neurologist geneticist. Sometimes skin biopsies are obtained for metabolic conditions. This is a very important thing, as we mentioned in the previous slides, to try to work the person's up for a neurodevelopmental disorder. And then the treatment of the seizure depends on the diagnosis of the neurodevelopmental disorder and or the type of seizure. There are examples of people who turn out to have mesial temporal sclerosis on the MRI, and it turns out that's the focus of the seizure, and a surgical resection can actually cure the seizure. So something like that depends on the diagnosis of the neurodevelopmental diagnosis of the seizure. And another example would be uncontrolled phenylketonuria. People who have uncontrolled phenylalanine levels are more prone to seizures, and better control of the PKU with the PKU diet can actually improve seizures and may really eliminate, with good control of the phenylalanine levels. Another example would be a severe vitamin D deficiency associated with hypocalcemia. If a person is prone to seizures, hypocalcemia can certainly exacerbate the problem, and simply correcting the vitamin D deficiency, or it could be a calcium deficiency. Celiac disease, malabsorption is not rare in people with developmental disabilities. It's actually been reported. The frequency is greater, so they're at greater risk for hypocalcemia as well as vitamin D deficiency. So it's important to think about medical problems that might have an impact on the seizure frequency. And then again, treatment modalities, I'm not going to give you lists of seizure drugs. You can look those up, but of course anti-epileptic medication, the older drugs, you have Dilan, phenobarbital, etc., Tegretol, Depakote, those are become older, and you have newer ones, Lamictal, Topamax, and then there's some newer ones, Banzel, and as an example, and there are new ones coming out. So work with a neurologist and try to select the best drugs. And then of course neurosurgery. There can be a lesionectomy, as I mentioned, temporal lobe resection, hemispherectomy, corpus callosotomy. These are all done, and and are effective in ameliorating and sometimes eliminating seizures. So certain selected patients may benefit from the neurosurgical approach. The ketogenic diet is used in children sometimes. There's really not much experience with this in the adult population. And the new thing is the vagal nerve stimulator. I think the final verdict is out on that, exactly how much benefit that would provide, but some neurologists feel it has an important role to play in treating seizures in persons with severe neurodevelopmental disorders or developmental disabilities. Now we're almost done with the talk, and I want to emphasize the importance of documentation, which requires a careful description of the seizure to make sure that you're really counting seizures, and then to determine the baseline frequency. And if you can wait, and get several months of baseline, and you may have that history from the families or staff, it's important to have a good baseline to know what the baseline fluctuation of the seizure activity can be. It can be once every 3 months. Person could be having daily seizures, and over the month's time there may be 10, 20, 30. It may vary from month to month. You need to get a feel for that so that you can see what the impact your treatment is going to have on that. Then you begin treatment, and you continue to document the response to treatment with longitudinal graphic analysis. And this is an example of longitudinal graphic analysis. You use an Excel graph to correlate the use of the drugs with the frequency of the seizures. Now, see in this slide, the seizures are recorded with the red line, and the person had been on Dilantin. You see in January, in the kind of green line, the seizure frequency was about 30 times per month. No, let me back up. It was about 22 times per month, looking at the red line, and the Dilantin dose was 300 milligrams. And throughout the graph, the Dilantin was the dose of the Dilantin continued at 300 milligrams. There was no change in the Dilantin dosage. And what happened in August is Lamictal was started at 2.5 milligrams and increased up to 20 milligrams per day. And you can see a couple of things you can conclude from this chart, this graph here, is that the Dilantin didn't appear to have any effect on the seizure frequency, although we don't have a baseline, you see, before the Dilantin was started. It could have been the seizure frequency was 50 times a month, and you started the Dilantin, and it improved to like 20, 25 times per month. But you can't tell from this graph. You need older graphs to look at, or past history to see how efficacious the Dilantin was, because if it's not efficacious, it's important to taper them off, taper slowly. The other thing to point out is the baseline fluctuation of the seizure. It varies from up to almost 30 times per month in May to as low as 12 times per month in April. So it can go up and down even when you do nothing, and that's because of the nature of seizures and the various metabolic effects. Calcium levels can fluctuate, electrolytes can fluctuate, stress in the environment. All these things may have an impact on seizure frequency. So if you had started the Lamictal in, well, let's say we started another drug that was not necessarily effective. You started it at one point, say February, and the seizure frequency went down to 12, say in April. You would say, well, it was the drug worked, but then it goes up again to like 27, 28. So you have to make sure that the treatment is affecting the seizure frequency beyond which the natural fluctuation or up and down frequency of the seizure is. So, but the Lamictal appeared to be effective because the frequency was well below the baseline. So, but this is an example of using longitudinal graphic analysis. This graph we call a treatment efficacy graph, and this type of system is useful for behavior, it's useful for seizures, or anything to provide you with a longitudinal documentation of efficacy of treatment. So in conclusion, seizures are common in adults with developmental disabilities. An attempt to determine the cause should be considered. If the cause is determined, the treatment may be based in part on treating the underlying cause, for example, PKU, drug toxicity, brain tumor, vitamin D, calcium deficiency, or electrolyte imbalance. If these conditions are corrected, then this may benefit the seizure. Other approaches include surgery and drugs, as we discussed, and regardless of the treatments chosen, efficacy should be documented, and highly recommended longitudinal graphic analysis as a way to approach documentation of efficacy, because it provides a record of what's been done, and other physicians may be taking the case, and it's important that they have that history. Okay, that concludes the talks. Thank you very much for listening. If you have any questions, you can contact me at ifcd.pmay@gmail.com. If you're interested in other talks related to chronic disabilities, go to our YouTube channel at youtube.com/user/PhilipMay123. Bye-bye.